Soon. Welcome everybody to our webinar this evening, Safe and Comprehensive Refractions from Across the Room to Across the Internet. My name is Dave Taylor. I'm Director of Product Management and Business Development at Rייכרט Technologies. And tonight I'm really pleased to present two wonderful speakers, James Timmons and Howard Freed, to talk about this subject and entertain questions and have some fun. Hope you're not all webinared out from the past year. We promise to make it concise and interesting and useful. So let's get going here with a couple of agenda notes and housekeeping items. So our speakers I've already introduced. Jim Timmons is going to talk about the current landscape here, what's going on around us and why this subject matter is relevant to us all this evening and the evolving standards of care. Spend a little bit of time talking about the subject of digital refraction, and of course Rייכrt's Phoropter VRx is part of that subject matter. And then Howard Freed is going to talk about teleoptometry and digital optometrics, which is a really fascinating subject that I know you'll enjoy. And we'll have a Q&A session. Speaking of Q&A, we would ask you to, if you have a question, to type it in, please, on your GoToMeeting control panel on the side of your screen. There's a section where you can type in a question, and I'll be kind of fielding those questions and directing them to the appropriate person to respond to. Somebody already asked a question if the webinar would be recorded for later viewing, and yes, the webinar is being recorded, and we will let all the attendees who registered know how to access that recording after the evening is over. We also have a few handouts over there in your GoToMeeting control panel, a few useful documents that you can download from there. There'll be a couple of audience polls during the evening that will launch, and you can vote on, kind of make it fun and interesting. And at the end of the webinar, please take a minute to take our survey, just a couple of brief questions about how we did and whatnot, so that we can improve and do better next time. So that's enough out of me. I think I want to introduce our first speaker, Jim Timmons, in a moment here. Jim is a graduate of Ohio State University College of Optometry. Did his residency at the Chillicothe VA Medical Center. He's the chairman of the Department of Clinical Sciences at the State University of New York. He developed the Glaucoma Institute there, where he was the first director of that Glaucoma Research Center. He co-founded Ophthalmic Consultants of Connecticut, which is a multidisciplinary referral practice that provides secondary and tertiary care. And he's received numerous awards for his service. Lots of publications and in glaucoma, dry eye, cornea, external disease, and refractive surgery technologies. I'm sure you've all seen Dr. Timmons on the podium at a show in the past. Our second speaker, Dr. Freed, tonight is a graduate from Johns Hopkins University, State University of New York College of Optometry. He's been practicing for over 20 years, owned and operated a commercial optical lab in the New York metro area, owned and operated retail optical businesses, and is the president and founder of DigitalOptometrics, which is a solution that permits patients to receive a comprehensive eye exam that can be performed by a licensed optometrist from a remote location for the patient. And as a result of that, he was named one of the top 20 innovators in telemedicine in 2020 by Technology Innovators magazine. So, two great speakers. And now I'm going to kick it off by getting rid of my camera, get my ugly mug off your screen, mute my microphone, and turn it over to the real professionals here, Dr. Timmons, to talk to you about digital refraction and why it's more important now than ever. Dr. Timmons, I'll advance the slides for you. If there's any problems going on, just tell me.
Well, Dave, thanks so much for the introduction, and thank you for joining us. Hopefully you'll, I think you'll find this very interesting. I have been overwhelmed by the technology. I've had it now for almost 2 years or so, maybe a little bit longer. And you might ask, I spend my time talking about ophthalmic disease and glaucoma and dry eye and refractive surgery issues. Why would I talk about this? Well, it turns out that I also talk about new technologies, and it's one of my favorite topics. And this is a technology that has really come of age. And I think for all of us, there's some very vivid and real applications now, and I think into the future, the applications are even more robust. So Dave, next slide, please. So everybody's been through a horrific year. I'm sure I talked to so many of you, and I talked to friends across the country. I talked to friends in the New England region, Connecticut. It's been difficult, and everybody's had to make adjustments. And one of the issues that has risen in that arena relative to making adjustments is the ability to undergo a telemedical consultation or some form of remote interaction with your patients. Just saw a survey that said 35% of all practices will continue to actively use telemedical interface for their patients, even after the pandemic's over, because it's such an efficient way to essentially triage individuals who are presenting to the office. And we certainly did that. And I think that it has been, I just did 2 today. I average 2 or 3 a day. Patients will call in, we'll do a triage visit over the phone, and then I'll make a decision as to whether we see them. We then get the information, we send it forward. So I think most of us have at least attempted or participated in that venue. And that says a lot about what Dr. Freed's going to talk about later relative to digital optometrics, which is a mechanism to effectively provide remote services in this dimension to patients who are either patients in the practice or new patients or individuals who can't attend the practice because of other issues. So we are in a new world, and all of us are going to continue to make those adaptations, and I think this is very interesting. Next, Dave. Look, our office has completely restructured itself. I'm sure all of yours have as well. That restructuring was based on your decision to follow the recommendations of the CDC, your regional and your national, regional and state governments. And in large part, it decreased the number of patients in the office. We all know that. It challenged our ergonomics, our flow patterns, and it also put us and our staff at risk of contact with patients relative to the proximity that we have to obtain in order to examine, and the duration of the time that we have to be there to examine as well. So we see so many patients in the office. I mean, I just saw 44 patients today. But within the context of that, we did a reasonable number of refractions, not for general care, but for patients of mine who are long-standing medical patients who need updated prescriptive services, or just for the simple fact of understanding what their best visual acuity is. And I think that's a critical part of the overall assessment. I have so many patients for which the pinhole is a total bust, as you all have, I'm sure, and you stick them behind a Phoropter, and all of a sudden their vision's infinitely better, and some of your concerns have been washed away. So increased safety and physical distancing, much more efficient, and we'll talk about how that fits in here in a second. Patient convenience, this is a little bit more in Howard's presentation, but certainly a convenience to individuals who use it in this larger domain. And then improved care, which is, I think, a remarkable step forward in the Phoropter world. Next slide, please, Dave. So this is a little bit of a summary, a much safer environment, and we'll talk about how that happens. Increase in efficiency and throughput, I would absolutely agree with that. I typically am not the person who does our refractions, although right now, because one of my externs was unable to attend this semester, everybody's having to chip in, and I will go ahead and join the staff and do whatever we need to do to get the day done. And I did about a half a dozen today, but I like to do them in this room, and so does my staff. So we'll talk a little bit about why. Improved ergonomics, very important. I think the differentiation is interesting. Patients are kind of overwhelmed by this. It's like, oh, you're over there? I said, yeah, I'm over here. We're controlling everything remotely, and I can actually do this, and we'll do some flipping of lenses or changing of eyes without touching the Phoropter, and they really appreciate the fact that this is a different level of technology than what they've been presented with previously. Patient convenience, certainly that's truth, and then increased focus on medical care. As I said, this is a large part. If you're providing medical care, one of the endpoints is best corrected vision and comfortable and safe vision for your patients, regardless of their presenting clinical signs and or final diagnosis. Next, please, Dave.
Well, this is the first opportunity we have for an audience poll, Dr. Timmons, so I'm going to pop that up. It should come up on your screen. We'll read the question out. Everybody gets a chance to vote. Since we're on the subject here, launch the poll. Do you utilize a digital Phoropter in your practice? Hopefully you're seeing that poll on your screens right now. The votes are coming in. Right now it's about 37% yes, 65% no. So it's shifting back and forth a little bit, but hovering roughly around 60-40.
So two-thirds, one-third.
Yep, exactly.
Okay, perfect.
I'm going to close that poll, and it should be back over to you now.
All right, yeah, next slide, that's great. So look, safety is a real issue. And for those of you who may have had either an exposure to COVID and had to quarantine, who have had staff members who have been exposed and or have had quarantine or had COVID, or whether you've had it, I can certainly give you a personal experience. I made it through 9 months of literally monk-like life. And the day after Christmas, I was diagnosed with COVID and then spent a pretty rough 2.5, 3 weeks after that in and out of the hospital and doing some other things, kind of recuperating and then getting back onto the office sort of protocols and moving forward with my schedule. But that was tough, and I wouldn't wish it on anybody. One of the ways to remove that is physical distancing. How does this work differently? I'll show you in a second. This is really remarkable. And this is actually one of the things that we love from the beginning, is I don't have to be anywhere near the Phoropter, neither do my staff. They can be in the room. They could be in another room if they wanted to with the Bluetooth technology and the cabling that's available. But we simply moved it a significant distance away from the room, from the Phoropter, sufficient enough that they had their normal CDC-approved 6 feet of space, and it really has changed the parameters of the examination. Next, please. So the other thing that has just been a godsend is this device is connected to all of your other devices. And as a result of that, the technician or yourself or myself will walk in the room and ARAK will already be in the Phoropter. You're not dialing anything, you're walking in, you're beginning the journey. It's a much faster and much more efficient process. So you have ARAK, you have you can get the patient's prior lens RX and put that in as well. And you can actually program those in and then simply flip from one to the other and say, this is where you were, this is what we found today. It's a brilliant way to provide refractive analysis, as opposed to the old school, which is, well, I can't really show you where you were because I have to click 17 lenses, but trust me, you're going to see this better. This is a vivid example to the patient, and I think it really helps them understand dramatically whether this is a notable improvement or whether it's simply a push. And both of those are important, because if you're going to prescribe something, that's an issue. I love the fact that I can change optotypes while I'm refracting, because the device actually has the ability to simply operate in multiple modalities. Utilize EMR to transfer all the RX information, so when we're done, you just push the button and it automatically goes to the EHR. You never have to worry about transcription errors. You don't have to worry about things getting lost. This is Bluetoothable to your devices, or you can have cables. It's Bluetooth transfer, right? I love the fact that when we're done and you simply say, yes, final RX, you go boom, right over to the EHR, and then that goes out into the patient's hand in the form of a printed document when they decide that that's what they want to do and we're done. This has been such a smooth transition for us in the office. Programming sequences. I don't use this as much as I probably should. My standard sort of refractive style is mine, and you can actually program that in. It'll automatically set you up. Obviously, it has plus or minus cylinder, which is fantastic, because in some practices, you have people who like one or the other. Most of optometrists, as we all know, are minus cylinder people. But if you work in a mixed practice like mine, some of my colleagues trained in plus cylinder, they found this amazing that they could actually go old school and do this and not have to convert over. It programs refractive sequences. So if you have a way that you like to refract a patient, you can program the sequence, and it automatically will follow that sequence if your technician's doing the refraction, so that they mimic your style and your pattern. And I think that's something that's really critical. You know, you can teach somebody how to do things, but in the end, you still have to have a system or a style. And this is something that allows you to do that, whereas with a standard Phoropter, it's not possible at all. And you can also program the acuity chart in a number of different ways. So you can go horizontal, you can go vertical. You can do that with other systems, but this links it into the Phoropter that we have, and it also allows you to manage it remotely. So next slide. This is a little bit of a comment about where we're headed. And, you know, Howard and I have talked about this extensively. And this is such an interesting and fascinating concept, especially with all of the remote testing that we're doing. I'm doing remote visual field testing now. We're soon going to be doing remote imaging testing in a study that we're doing with one of the local clinics. This is the future, colleagues. There is no doubt that this is going to happen. Remote evaluation of your patients was done throughout COVID with telemedicine, and there were some limits on that. You know, you could limit it to the anterior segment. This changes the entirety. I mean, we're talking about refraction now, but you know, in the right setting, you can actually physically examine a patient remotely from where you are, so long as they're in the office, and that's amazing to me. Not that I would want to be in the Bahamas doing refractions, because if I was in the Bahamas, I wouldn't be doing refractions, but or general examinations or comprehensive assessments. But it has the capacity to do that. And Howard's going to elaborate on that. I think you're going to find this really fascinating. Next, please. Ergonomics. This is interesting. I don't know if you're aware of this, but one of the primary diseases of optometrists and ophthalmologists, if you look through the literature on the medical side, is the simple fact that we end up with neck problems, neck and back problems. We are constantly hunched over the slit lamp. More importantly, rotator cuffs are one of the common problems that optometrists and ophthalmologists suffer, or the technicians are there, because you're constantly sitting down and reaching up. You know, one of the things that I learned quite a while back from one of my early instructors at SUNY, one of the people I met, not my instructor, one of my early faculty at SUNY, was I refract standing up. Why? Because if you reach up all the time, your rotator cuff's going to go. We put ourselves in these micro ergonomic stress moments, and this device just completely eliminates that. You're sitting in a comfortable position. You have control of the device. You can have it on a little table. You can pull it up close. You can tuck it back into the wall. You can do it from across the room, which is amazing. You can be 10 feet away. You can be 2 feet away. Your choice. Love the fact that you're in a comfortable place. You're doing it in an easy and comfortable environment. I think it also makes the concept of the examination less sort of strained. I know a lot of times you'll be standing there, it's like better one or two, better one or two. This is easy. Touch the button, touch the button, touch the button, touch the button. You can also face your patient while you're doing this. You can get a sense of whether they're right positioned properly. There's a lot of advantages. And you can see what your patient is seeing on the controller. So I think one of the biggest issues in eye care is you want to differentiate yourself. Differentiation is the key. I think we differentiate in our practice on a daily basis with the level of technology that we present in the assessment and the final diagnosis and treatment of our patients. I think we also differentiate with the quality of the care that we render. And all of you do this. But when you have an instrument that's probably one of your most commonly used devices, slit lamp, Phoropter, let's be truthful, and you are substantially different, patients understand that that difference is a level of commitment by you to them, and they also see it as a level of technology stepping forward, and the participation between you and the patient then becomes a very different exchange. It's honestly, in the beginning, this was a wow factor. A lot of the patients have been back, and it's the second time around. The new patients are always astounded by the fact that they can indeed go ahead and have an examination, and I'm sitting on the other side of the room and controlling everything, and they really like it. We don't do a lot of social media. That's just not our style. We're busy enough and blessed with the fact that we're very busy, and we really don't do that. But in practices that are growing and practices that are differentiating against competition in the community, this is a great way to sort of amp up the awareness of your practice being a better opportunity for your patients or individuals who attend to you. So I don't really deal with this side at all. We don't do it, but I can assure you that the colleagues I know who have the system, and we've talked about it extensively, they all tell me that everything in the practice goes up as a result of this part of the practice taking that step forward. So next, please. So there's an increased demand for medical eye care. We all understand that. What's interesting, and this is, my day-to-day, I saw 44 patients today. So my day-to-day practice is about that, 40 to 45, maybe sometimes on a busy day, I must see 50. But the key is that most of my patients are seniors. And you would think, well, they've had cataract surgery, they've had this, they've had that. The demand for RX work is not that great. Excuse me, it's just the opposite. This is a very high demand group. And part of the reason that this is interesting is if you're going to manage them medically, if you're going to take care of their glaucoma, if you're going to take care of their macular issues, if you're going to help them with their visual needs relative to reduced acuity, if you're going to manage dry eye, if you're going to do cataract assessment, co-management, refractive assessment, co-management, all of those require you to invest on the medical side, but this tool is such a perfect adjunct or companion to that. And I find this to be a great fit in a practice that sees only medical patients, ostensibly. I mean, we really don't do any general eye care. We don't take vision plans at all. But I do a lot of refractions, and it blends perfectly because it matches my other technologies that we have moved forward. And so it makes the whole office a technology haven. And patients really, really do appreciate that. First line care, absolutely. You know, it keeps patients educated about your healthcare. Optometrists are, as we know, we are the primary eye care physicians. Love the fact that it's programmable. You'll be amazed by that. And it helps you understand the big picture of how to grow the practice from the inside out. And that's sort of my spin on why I think this is such an important device. So next slide, please, Dave. I think I am just about done.
Well, we got an audience poll here on this slide, but you know, okay. A question came in, Dr. Timmons, on that last slide there, related to medical, as to whether or not this connectivity and all this sort of stuff, you know, the digital Phoropter really meaningfully frees you up to spend more time on medical, or is that just?
Well, first off, in my practice, what it's done is if I'm doing the refractions, it absolutely allows me to go much quicker because everything's being fed into the system. There's no delays. I walk in the room. I have my 1, 2, 3 pattern that I produce. I mean, look, you could have your technicians go in and dial everything in, but that's taking up their time, right? They've already done the measurements. Let them just go ahead and make the transfer. The second part is my technicians, the people I work with, they love this device. You know, if they're going to do this type of testing for a patient, somebody says, hey, look, you know, I came in today, it's my glaucoma follow-up, but I really would like to see whether I can improve my vision. Absolutely, happy to provide that service. The technicians love this unit, and they can immediately just Bluetooth it to the EHR, which is fantastic. So yes, I think there are many places in the progression of the evaluation of the patient where this is a time saver. It's much more efficient. I think for whatever reason, I just find it less stressful. I don't know why. I think it's because you're sitting down and you're sort of in a relaxed position. You're not standing. I stand up otherwise. And the other thing I like with this one is I don't have to worry. And I know this is for those of you who are not yet in presbyopia world. This is fantastic because I can actually see all the numbers that I'm working with without having to stand there and look around the Phoropter and get underneath my bifocal and try to see what's going on. And that's probably one of the more interesting aspects of this is that you're front facing to the patient and everything you're doing is in a print type that doesn't even require you to wear, I don't have to wear my glasses to do the refraction. Every other time if I'm in one of the other rooms where I might see that patient, I have to do that. So yeah, I do think there's a lot of advantages to this.
So here's our second audience poll tonight. Everybody gets a chance to participate again. This poll is about delegation in your practice. The poll should be live on your screen right now. And the question is, do you delegate your pretest, things like lensometry and autorefraction? Do you delegate pretest and refraction to technicians, or do you do it all yourself? And right now, we are getting about 75% delegate the pretest stuff. About 10% do the pretest, delegate the pretest and refraction, and about 12% right now do it all yourself. And that looks like the results have stopped coming in, so we're going to close out the poll right there. And I think that might have been your last slide, Dr. Timmons.
Yeah, I think so too. Yep.
Perfect. Thank you very much, Dr. Timmons. Appreciate that. Yep, you're right. Absolutely. That was the segue for Dr. Freed. Dr. Freed, I see you on the screen now to talk about telemedicine innovation and digital optometrics. You can see the slides?
Yes, I can.
Okay.
Very good. Thanks.
Here we go.
Yeah, thank you for putting up the first one, and thank you everyone for joining this evening. I know it's getting late, and I will tell you from someone that graduated in SUNY Optometry in the mid-90s, when I knew Dr. Timmons back then as one of the gurus of our optometric profession. I never would have thought back then that I would be following him in a webinar, and so it's truly an honor to do so. So thank you for that, and thank you to the Rייכrט team for having me tonight. So yeah, you can go down the other bullet points up to the 70% one, and there's maybe one more, maybe. Great, perfect. Yeah, so back, you know, and I think Dave gave you a little bit of my history. So, you know, I was came out of SUNY Optometry, and I was in the optical retail environment. I had multiple stores, and then I also had the wholesale lab business that I sold to Essilor. And back in 2015, 2016, I was just looking at the landscape of optometry, and I was getting tons of friends in the industry that were coming to me and asking if I can assist them in finding doctors of optometry to fill in. And you know, the landscape is changing and has been changing. And yes, there's over 300 people in 300 million people in the U.S. and 200 million of them require some form of eye care. And of them, only 100 million are actually receiving an annual eye exam for a number of different factors as to why they're not coming on an annual basis, that 100 million. But the landscape is also changing in the optometry schools. And so you have 70% of the graduates are now women, which is a big positive. As Dr. Timmons you know, implied earlier, there's more of a focus on medical eye care, which is also fantastic, what they're teaching now in the schools. But what we are finding is that back then, at least in 2015 and 2016, there were new technologies that were coming out, and those technologies were, in my humble opinion as an optometrist, were not really, you know, very responsible. You know, they were direct to patient, what they called direct to consumer technologies that were refractive only solutions, and actually optometrists were being sort of pushed out into the cold because it was really only ophthalmologists that were ultimately signing off on these RXs that were being performed by these objective, you know, autorefractor type of hocus pocus kinds of stuff. And so, you know, I had an issue with the technologies that were out there at the time, and I knew that we could figure out something that was, well, that was more patient centric. And if you can go to the next slide for a sec, Dave. So, you know, ultimately what I wanted to try and do is to develop something that actually kept the doctor-patient relationship intact. As I said before, a patient-centric but OD-driven model. And I think that was critically important, that patients would be able to see their doctor, because most patients have 3, 4, 5 questions they want to ask, you know, their doctor, and so that they can have a synchronous visit with them. But also, just as importantly, that we kept ocular health and refraction married together. And I think that was a problem with those early technologies, that they were just refractive only solutions. And I really felt that they were being shortchanged because, listen, optometrists are the gatekeepers to the healthcare system. And as you know, most patients are going to come and see us because they're having trouble seeing for distance, or they're having trouble seeing for reading. But when they sit in that chair, we're also looking for diabetes and hypertension and glaucoma and cataracts. And so all those technologies, whether they're cell phones on, you know, sticks or whatever else that they had developed, you know, yes, they're going to solve the patient's problem for seeing at distance and reading potentially, but at what cost? You know, are we going to lose out on early detection of disease because they've separated out refraction and ocular health? So that was a critical part of why I wanted to develop a technology to go ahead and find a responsible solution, again, patient-centric and OD-driven. Okay, so we can go to the next slide. So ultimately what came about was we developed DigitalOptometrics, and it does, and we're going to get into what it, you know, the details of it, but it does boost efficiencies and reduce costs because, you know, imagine like one doctor who is licensed in multiple states, let's say New York and California. They can examine one patient in Brooklyn, New York, and 5 minutes later, they're going to examine a patient in San Francisco, California. And so imagine being able to expand your practice to locations where you're really not limited by where you're physically located. So you're going to be able to utilize yourself as a doctor, being able to see patients in multiple locations, even if it's within the same state, or you can go ahead and utilize the Digital Optometrics network of providers when you're not available to see patients. And so you can go ahead and, 7 days a week, you can, we have an open and a closed system, so we can actually provide doctors, or you can go ahead and utilize your own doctors 7 days a week to see patients. And then, of course, there's the safety issue, what Dr. Timmons was referring to before. Although we did, obviously, we developed this well before COVID, but this improves distancing significantly. And then, the exams have through this technology take less than 30 minutes. We actually have a number of customers that are seeing 3 patients an hour through the technology. And what you're seeing here is a number of the different images of the technology. And I'm actually going to take you through, it from the patient experience perspective. So if we can advance to the next slide, we're going to go relatively quickly through this. So, the patient will come into your practice, and let's say the doctor is not there, although we are in environments where we actually work side by side with in-person doctors in multiple exam room settings. But the patient will come in, and the doctor is always available 7 days a week, as I said before. And so next slide, they will go ahead and fill out their ocular and medical history and their demographics on a tablet. And that could also be done by a local technician or some sort of telepresenter that actually, brings the patient through the entire journey. It can actually help by putting it into a laptop or a desktop. And actually, if you have an EMR, we can actually go ahead and integrate with the EMR and push the information that's an existing patient into our system. Ours is a cloud-based system. And then what is going to happen is this facilitator or local technician will bring the patient into the pre-testing area, which is what you're seeing here. And what we do with the pre-testing area is we try to utilize devices that you already have. So we try to reduce the CapEx by using what you have. And as you're seeing here, we're using Rייכrט. We can use an NCT like the 7 or 7CR. We can use retinal cameras and visual fields and video slit lamps, autorefractors, auto lens meters. We can get involved in medical devices. We can get involved with topographers and B-scans and OCTs. But we integrate with hundreds of devices. And we, as I said, that's for the purposes of reducing the CapEx. There's certain minimum requirements that we have that we need in order to be able to examine both the anterior and the posterior side of the eye. But again, we try to utilize what you have. So all of this information is going to be pushed up through our machine interface software up to the cloud to be reviewed by the remote optometrist. And then the patient is led into the exam room, which is what you're seeing here. And you can go to the next slide. And what's going to happen is a remote technician who is remotely based, works in our office in either New York or Cincinnati, and some of them are even working remotely from their home offices. We have about 75 remote technicians who take control of phoropters all around North America and perform full subjective refractions utilizing the Rייכrט VRx digital phoropter. And they will go ahead and perform a full subjective refraction from unaided visual acuities all the way through the red, green, and binocular balance. And you can go to the next slide just to see an example of our call center here, where the techs will see the patient on the left side of the screen, and on the right side of the screen, they will have the Rייכrט VRx digital phoropter software where they can control the actual phoropter. And you can go to the next slide. And so, as I said, they'll control it. Next slide. Then what happens is they come off the screen after doing that initial subjective refraction. And by the way, in certain jurisdictions, you might be asking yourself, well, wait a minute, why? I may not want the refractionist to do it. I want to do it myself as an optometrist. And you can do that. You can skip the remote tech and go straight to the doctor. The doctor also has the ability to go ahead and take control of the Rייכrט VRx digital phoropter. And they can go ahead and refine anything that the remote tech did, unless they do it completely themselves. But you're seeing here a picture of the doctor on the screen communicating live with the patient. And when they're communicating live with the patient, not only can they control the phoropter, but they can also put up images of the retina on our whiteboard technology, and circle the optic nerve and the macula, and on the patient side, they're seeing the pen mark moving sort of like you would on a NFL football game. It's a very engaging experience. They can give recommendations for lenses and give recommendations for ocular health, follow-up, assessment, or referral for that matter. And so, of course, critically, they can go, important that they can answer any questions that the patient might have. Next slide, before they ultimately sign off on the RX for glasses and or contact lenses, at which point, Dave, you can go to the next slide.
Howard, we got a question that just came in here. It's perfectly relevant to the screen.
Sure.
The question is somebody's asking, is that doctor, assuming they're talking about the doctor they see on the screen here, me or another doctor? And I think the answer is it could be either, right?
Could be either. Yeah, it's a great question. So we have both an open system, which means that DigitalOptometrics will provide not only the refractionist who performs the initial subjective, but we will also provide the doctor who is licensed in the state in which the patient is located. And we will also, in addition to that, get them credentialed on whatever plans and get them linked to your location so that you can bill through their NPI number. And then, of course, there's the closed system, which would allow you to be the doctor. And it could also be a mix of the two. So, there could be times when you want to be the doctor for your own practice or your associates, or for that matter, you certain days and hours that you want us to cover for you. And we can certainly customize that based upon your indications of what you want us to do. And then, you can go to the next slide, then the doctor will answer those questions. And then next slide, they can go ahead and the prescription will print locally so that the patient can go into the dispensary to purchase, whether it's the eyeglasses or contact lenses. So on this slide, this is really just a summary of what we just talked about, which is that it's a comprehensive eye exam, which is critically important for us, that we do everything as a comprehensive eye exam. It's not refractive only. There is real-time communication. This is synchronous. And the exam cost is reduced substantially because this is not a fixed cost. Currently, you're used to paying a doctor for the full day that they're available. And with our model, it's a variable cost. You just pay on a per exam basis. So if you have 2 exams that we're covering you for, or 7 exams or 30 exams, you just pay on a per exam basis. The patient experience is now exciting and enjoyable. We actually go ahead and run Net Promoter Score surveys. For those that don't know what that is, the Fortune 500 companies use Net Promoter Scores to assess loyalty and customer satisfaction. It's really the main question for NPS is, would you recommend this product or service to a friend or family? And it's on a 10-point scale. And you have major companies like Apple and Amazon and Netflix. They have scores in the 50s and 60s, which are excellent NPS scores. Our score for DigitalOptometrics after performing 250,000 exams is in the upper 80s, which is unheard of. And actually, we ran it based upon age, and the older population actually gives us a higher score than the younger population because it's really a wow effect for them. The younger population is accustomed to telehealth. The older population is now as well because of COVID. We can go to the next slide. But yeah, the older population does love it. Excuse me. So now, doctors can go ahead and conduct exams during all business hours, 7 days a week. There's greater access to care. I talked about there being a variable cost. And you can actually go ahead and have one doctor that can examine patients in multiple locations. And the system is designed for utilization by not only the remote doctor, but also the on-site doctor. So it's the same exact equipment that you'd be utilizing just with a flip of a switch. So if you have an on-site doctor that's there using the Rייכrט VRx and they want to leave at 4 o'clock, they just flip the switch and now it can be remotely controlled, whether it's by the same doctor at home or as Dr. Timmons says, actually, I probably wouldn't mind seeing patients from the Bahamas. We've actually had patients being seen by doctors in Israel. So as long as there's an internet connection, you really could be seeing it. And understand you have to be licensed where the patient is located. So that's just the other thing. But yeah, just a flip of a switch. Okay, next slide, please. So the advantages for patients, this was developed prior to COVID. We saw the advantages, for some of the reasons why I told you when I first started speaking earlier this evening. And because, there are remote parts of the country where there's a lot of what we call dark locations, meaning they can't find doctors in remote parts of the country, and even urban areas where there are difficulty in finding doctors for certain days and hours. We go into dim environments, what we call dim, which means there's a doctor, in the location 1, 2, or 3 days a week. But for whatever the reason is, maybe either because I can't find a doctor, or for that matter, it just economically doesn't make sense to have a doctor on those full days. We go into those dim environments, so they add us the other days and hours that the physical doctor, who's on site is not there. And then we go into high volume locations where there's a doctor in exam room 1 and we're in exam room 2 and 3. Why would they do that? Well, that's really about meeting patient demand. It's about convenience. In this world of Amazon, it's all about convenience. We're reducing wait times. We're lowering no-show rates. And so everyone really wants to be seen at the same time. They all want to be seen during lunch hours or on the evenings or weekends. And so by being able to have now multiple lanes being utilized in addition to the on-site doctor, which I love that idea, because you now have the ability to even push some of the cases that perhaps aren't really perfect for telehealth to the on-site doctor who is available. And so that's, just many of the advantages of doing that. Next slide, great. And then advantages for optometrists. Well, listen, work-life balance, as you know, is #1 driver for young optometrists now. I will tell you that this is just one tool in the optometrist toolbox, and what's so phenomenal about our profession is that you really have the ability to do so many things now, and this is just one of them, to be able to practice in this mode. And so it could just be one tool in your toolbox, and just, I think it's really exciting that people, for whatever the reason might be, whether it's due to the COVID pandemic or because you're taking care of elderly or children or other personal reasons why you need to be in a different state, but still be able to have your practice. Let's say you're semi-retired and you want to keep the revenues strong and still be able to see your patients. So there's just so many different reasons why these are advantages for optometrists that were just not possible, this technology, a number of years ago. Next slide. Yeah, so here's the fully integrated, whoops, yep, that's the one, yep, that's perfect. And so, listen, a lot of the other technologies I talked about earlier that, the hocus pocus ones that I was saying were really refractive only solutions, they have developed their own kinds of things to be able to be utilized that are sold to you. And in our model, we're actually using, equipment that is already trusted brands. And so here, like for instance, the digital Phoropter, the Phoropter VRx by Rייכrט, and you'll see on the top line, the second to the right, the second all the way over, actually, the fourth one over, that video slit lamp, which is probably unique to our model, and that's brought in and distributed by Rייכrט, and it's a phenomenal unit that we teach local technicians how to utilize, and it's a 15-second video, and you're able to take as many of them as you want, but we get to see von Herrichs and cornea and conjunctiva and lid margin and lens. But all, as I said before, we integrate into hundreds of devices, so you have the ability to go ahead and try to replicate as closely as possible. And we don't perform dilations through this. We do recommend them for the patients to come back from dilations, but we, other than the dilation, this is really as close of a replication to an in-person exam as possible. And that's really what we want to do. We want to replicate the in-person experience, but this, remember, is a supplement to the in-person experience, not a replacement to the in-person experience.
Here's a question, Howard, relevant to this slide here. Somebody asked about all of these pre-test things, fundus photography and so forth, whether that's archived for later viewing, or does the doctor see those things in real time during the examination?
Yeah, it's a great question. What happens is that the local tech will go ahead and bring the patient through all the pre-testing, and then everything is uploaded. So it's not synchronous in that you're seeing it while the local tech is doing it, but it's within seconds after the local tech is completed doing it in the pre-testing. You will be able to review everything while you're communicating live with the patient. So you'll be able to tell them, okay, I'm looking at your the front surface of your eye now, and we also perform all of the entrance tests like pupils, cover on cover, EOMs, with a webcam, and we record that and send it up as well. So within minutes of this being completed, you'll be able to be reviewing it while the refractionist is actually performing the initial subjective refraction. You can start reviewing it, and then you'll be able to have a live conversation with the patient while you continue to review it in front of them. And so this last slide is really just to let you know, I mentioned before, we've performed over 250,000 exams. Our redo rates are a fraction of 1%. We have performed a research study with the Illinois College of Optometry that is going to be published at ARVO at the national meeting this year. And that just proved out that the results of our exams are similar to an in-person exam. We're actually now doing a long-term study with the University of Montreal, the optometry school there. And I know that one of the questions that's going to come up, so I'll just hit it now, is about insurance. Yes, all of the major vision insurance companies now reimburse for our technology, from VSP to IMED, Davis, Superior, Spectera, Medicare, and many of the state Medicaid programs are reimbursing at the full rates as an in-person exam. So I know that will probably come up. And I think I'm going to pause here. I think the next slide, it's going back to you, Dave.
Yeah, but let's take a break right here before we get into this and bring Dr. Timmons back on if you're still hanging around, Jim, to answer a few questions that have come in during both presentations. And let me see if I can.
Okay.
Hi, Jim. All right. So I think the first one that I didn't get to yet was during your presentation, Dr. Timmons, asking, how does a system like this, VRx, I assume, help when determining computer distance? And then there's another question related to close vision testing.
Look, it has all of the standard formats that you would want. So you can do raw testing, you can do anything you like. I've actually changed my perspective on that space, and I typically kind of move my patient out from behind the Phoropter for near testing now, once we have the distance RX, and we talk about where are you located at. Show me your distance. Is it out here? Is it over here? Do you have 2 screens? Do you have 4 screens? I think the traditional concept of a standardized near point analysis is fading away with the advent of tablets and multiple workstations. So I'm much more concerned about the ergonomics of their space. And I think Howard would probably agree on this. I typically have a lot of patients who have multiple pairs of glasses because their workspace isn't their life space. They're in front of screens all day and they have to read something here. So we get a set of lenses that give them max up here. The top is not distance, it's actually computer. The bottom's reading, and they'd like to take them off, put them on the desk, and walk away, and then they put their regular specs on when they leave. Right, Howard?
I agree 100%.
Yeah, so I've moved away from the near point. Now, the Phoropter stuff relative to cover tests, I think that's valuable, and you can do that with this device as well. There's no restrictions on that. So
we have a question about dilation, as whether or not that's passé now, and I know I would assume that the fundus cameras that that are compatible with the DigitalOptometrics system are non-midriatic fundus cameras, and you're getting a good view of the back of the eye. But how do you respond to the question about dilation?
Yeah, it's a great question, and I will tell you, probably in 70% of the clients that we're currently in right now and integrated within, they're using Optos, which is, as you know, a wide field non-midriatic camera, going out 200 degrees, and so that's one option. The other 30% are using a 45-degree, central view, but yes, I mean, you have to also understand what this is really utilized for. This is a great gatekeeper approach to optometry. But again, as I said before, this is a supplement to the in-person experience, not a replacement. So, so I'm not going to, stand here and say that, we need to eliminate dilations, from what we do. But I will tell you that we get a very good view of the retina with the technology that's out there today.
Yeah, I actually have the other side of that technology. I have the Zeiss Claris,
Yep.
And I would submit that I have never seen the retina in that detail in my 38 years of practice. We can do the 4-shot. Does it completely eliminate dilation? No, it doesn't. Does it give you the ability to dilate the patient less frequently to get to where you want to? Absolutely. In my diabetics, I rarely have to dilate them more than once a year or maybe even less, simply because we see so much into the periphery with that camera. And the beauty of the camera is, and I'm going to be very honest, if you think you're doing a really good job with a BIO and a patient squeezing and tearing and moving and not going where you want, you are probably convincing yourself that the Goldmann tonometer is still the standard of care for measuring IOP. It's not, colleagues. The camera that we have allows me to just stand there in front of it and go, oh, there's a microaneurysm. I didn't see that choroidal nevus because the patient wouldn't look in that direction. So I think the conjunction of those two demand. Look, when a patient comes in with PVD complaints, everybody gets dilated. If they're high myope, they get dilated. But the current recommendations from our organization and the Academy of Ophthalmology do not say that you dilate the patient every year unless they have specific preconditions that would require that. You dilate the patient on symptoms, you dilate the patient on some form of cycle. But for the average person coming back for their general comprehensive exam who was completely healthy the last time you saw their peripheral retina with no new symptoms, you probably don't need a dilation every year. What you need is a comprehensive exam that covers all the material Howard did. And basically, we do this exact same thing simply because we have all that connectivity as well. And I've added this into the system because this is sort of the last piece in my technology leap. And it has really sort of cemented everything else together in a very nice way. So,
last question here, I think, is for Howard, is how effective is it versus in agreement with in-person testing? So I think you touched on that, talking about the study at ICO.
Yes, the ICO ran that research study to prove out that it was similar to the in-person experience, and the results, the same results. So listen, this is unlike, as I said, taking an objective autorefractor and going ahead and prescribing off of it. We're doing the same exact subjective refraction that you would do if you were literally inside the exam room with the patient. So it's going to come up with the same exact results as if you were there. So I don't think you're going to find any difference, from the remote exam versus the in-person exam.
Someone made a comment about maybe it's time for a national license for optometry. You have any thoughts on that, Howard?
I love whoever just said that. I've been preaching that one for quite some time, and I believe I see Jim wants to say something about that, so I'll let you knock it out of the park for that one.
Yeah, Howard and I agree for probably the same reasons and different reasons at the same time. I've been asking our national organization to come up with a way to homogenize the graduate degree, the professional degree in optometry for at least 20 years. The problem is the states have these vested interests. And you see that, sort of nationally on a political basis, regardless of what's red or blue, everybody has their own vested interests and they have their own needs. And there's a lot of protectionism that took place. I think that's just bad for the profession. I think it tends to skew people towards locations, and it doesn't allow for even and sort of on-need distribution of professionals. Medicine got by that a long time ago. That was the best thing they ever did, was to make the license universal and allow you to go everywhere. I think that's just absolutely critical. So I also would tell you, you're probably not going to see it anytime soon. So.
I don't think we're going to see this anytime soon. I spoke at the 100th anniversary of ARBO, the Association of Regulatory Boards of Optometry, and asked that same exact thing about license portability. And we're seeing it really, a lot of this going on now during COVID, where you can get temporary licenses in many states with an outside license, but it's temporary, and they're going to revert back. And I think as Dr. Timmons said, it really is about protectionism, but we do need to do something about that. That was a great question.
Yeah.
So a few closing comments here about the Phoropter VRx, which Dr. Timmons utilizes and is compatible with the DigitalOptometrics system. A few of the things that make it unique. One is the retractable prisms. You look at some of the autophoropters on the market, and they're pretty thick and chunky. And rather than having patients staring through a big stack of lenses and plastic, we have a very, very thin aperture area on our Phoropter VRx, and that's made possible by the fact that the prisms slide in and out when you utilize them only. So normally those are retracted and out of the way. The lens exchange and all the motors on this instrument are really fast and really quiet. Next time there's an in-person trade show, which I hope is not too far off, come and take a look at one if you haven't seen one, and I know you'll be impressed by how quick the lens exchange is and how quiet the lens exchange is. And that's part of the patient wow factor also that Dr. Timmons talked about earlier. You know, it's not only that the doctor is 10 feet across the room, that these lenses are flying by quickly and quietly. It's really impressive. We've got a split cylinder test. You see there the red, green, and that enables patients to see 1 and 2 at the same time, and maybe save you from having to flip back and forth so many times. And another thing about the system that's really unique and advantageous, and this plays particularly well into the digital optometrics situation, is that this device plays well with others. It is not a closed loop system. Because you buy a Rייכרט VRx does not mean you need to buy a Rייכrט autorefractor and a Rייכrט lensometer. Of course, we'd love for you to do that, but if you're happy with your existing autorefractor and lensometer, you can buy a new digital autophoropter, and it will integrate with almost anything that's out there. The touch screen and the controls are very logical and well laid out. They're also very, very robust. You put your hands on this instrument and you notice that it's made out of metal, feels very, very robust. We take a lot of pride in our quality, and anybody that uses a Rייכrט Phoropter knows that. These are made in Buffalo, New York, where I am here. So Rייכrט is the only major manufacturer of ophthalmic instruments in the US, and we've been manufacturing instruments in the Buffalo area since somewhere around 1920 or so. We are, by the way, just in case you didn't know this, the word Phoropter with an OR belongs to Rייכrט. We invented that word. It's a registered trademark of Rייכrט. Everything else is supposed to be called a refractor, although the term Phoropter with an ER has kind of become like Kleenex these days. That word Phoropter is something that we created.
So Dave, I have to stop you for a second. Dave, I learn something from you every time I talk to you. This is the first time I've ever heard this. That's a pretty amazing piece of history that you guys own the copy or own the patent to that. Thanks.
Own the registered trademark on Phoropter, and also the shape and configuration of the instrument is registered to Rייכrט as well. So these devices are a long part of our heritage, and they've been built in Buffalo, New York since before I was born. And we have a lot of different options. We have manual Phoropters, we have white and black and plus and minus, and illuminated and non-illuminated, a couple of different models of digital Phoropters. We are the Phoropter company. We've been making Phoropters for a long time, and we do better than anybody else at it. We can do a virtual demo for you. So these days, and we had this capability before, it was cool, but now it's really cool and really necessary. There's a picture of one of our application specialists, Kristen, down there. We can walk you through the system over an online meeting, answer your questions, show you how it gets used, and all that type of stuff in real time. If you want to do a virtual demonstration of the system, please contact us after the webinar, and we can set that up for you. We already did the questions. I think the last thing I want to mention here is we've got a couple of other webinars coming up in our spring education series here. We've got a great webinar coming up next week, Wednesday, the 24th, to talk about ocular response analyzer, corneal hysteresis, and IOPCC. I know that's another technology that Dr. Timmons uses in his practice. We're going to have Ike Ahmed, Paul Singh, Felipe Medeiros, and Justin Schweitzer talk about the evidence and the importance of those glaucoma vital signs you may be missing. And then April 8th, we have an interesting webinar on the CAT stenometer prism. CAT stands for correcting applanation surface. And Dr. McCafferty, the inventor of that new prism, along with Nate Radcliffe and Paul Karpecki, are going to talk about how that can help you make better IOP measurements with your existing Goldman tonometer. So that's all I have tonight. I want to thank Dr. Freed and Dr. Timmons again for joining us. When I close the webinar out here, you'll get a survey. We ask that you just spend 1 extra minute and please fill out that survey so we know how we did. And we look forward to seeing you all in the future. on another webinar and hopefully in person at the trade show sometime soon. Thanks everybody for joining us. Have a good night.
Sounds good. Thanks so much. Bye-bye.
Take care.
Bye.